Hello, and welcome to another edition of Let's Talk SADS Live, the Canadian edition. And delighted to be here. I'm your host, Dr. Shu Sanitani, and I'm coming to you live from Vancouver, British Columbia. And really glad to be here. Excited to have episode 25 of our webcast. And I lied, it's 24. Just testing you there. And as always, really proud to be part of this collaborative place where we come together really to talk about SADS conditions, sudden arrhythmia death syndromes, SADS conditions that have impacted many of you. Many of you are healthcare providers. I know some of you are joining in on the recorded version and the peace and quiet of your downtime. So really appreciate everybody joining. So what are we doing here? So let's just take a moment here to just remind ourselves here. I'm going to share slides. I'm technologically slow this morning. Must be the upcoming time change. So yes, episode 24 and SADS conditions and medications. So more on that later. Really glad to have some great organizations supporting us. And here are some of the companies that are really breaking into the novel therapies, and particularly relevant for our session today, where we are going to talk about some of the different ways to treat the SADS conditions. And many of you are familiar with medications, and some of you have been paying attention to new studies out there and new treatments available. So thank you. We really appreciate your support, and hopefully have made it easier. You can check out our website, lots and lots of great resources on the website, including information about specific SADS conditions, and also just some great information to pass on to your family to help them understand, and sometimes even your healthcare provider. There's not that many healthcare providers who are familiar with SADS conditions, so it's quite a specialized group of conditions and practitioners. Our guest was just saying that rare only is a statistic, and if you have a SADS condition, it doesn't really matter if it's rare or not. So thank you for that. So feel free to head to our website and click on the link to donate. Part of your donations go towards this webcast and other educational material, including webinars, and just in general, keeping you informed and connected. So really exciting growth that we've had in our SADS Foundation the last couple of years. So a little plug for November. This month we went off schedule a little bit. And so we are doing a close to Halloween episode, but we'll be back to our usual time, the third Tuesday of the month in November. And looking forward to having a chat with Dr. Michael Fridman from Calgary. And we're going to be talking about research, which is, of course, a huge topic that we're hoping to shed light on. So that is next month. Now, those of you who have been following along, especially this year, we changed it up a little bit from last year's Canadian icons, and we're just talking about some fun facts, and we're getting close to the end of the calendar year, hard to believe. And last year we had a little contest about these facts, and someone won some cash. And we haven't revealed yet what our plan is for this year, but excited to work on that with the team at the SADS Foundation. And I'd be remiss not to thank Pam Husband and Adrian, who helped put this on. And of course, we are very closely connected to our American SADS partners with Aaron and Alice Lara helping us here. And they are getting very close to their in-person meeting. Of course, we'll have good Canadian representation there as well. That's in Chicago on the upcoming weekend. And the in-person component sold out. So thankfully, it's also going to be live streamed. And check out the SADS US website for how you get connected with the live stream. We might even put something in the chat here, how to do that. So yes, thank you. Right on cue. So fantastic AV support that I have. So here's just some of a quick reminder of some of our fun facts. We talked about catecholaminergic polymorphic VT, CPVT. And I'll just say I was really honored to be a guest on Robert Pass's podcast. He does a podcast called PD Heart. It's not SADS focused, but every once in a while there will be a SADS topic, and we talked about CPVT this past Friday. So that is also another interesting source of information, and he does a nice job. I'm sort of jealous of his interviewing skills, and he opens it and closes it with fantastic music, something that we could think about. So carrying on here, we've got some fun trivia. Bidirectional ventricular tachycardia and CPVT, the discovery of ARVC and Brugada, and then certainly arrhythmogenic right ventricular dysplasia. And we still talk about the names of arrhythmogenic cardiomyopathy. Even last week at the Canadian Cardiovascular meeting, we were talking about it. A little bit about long QT syndrome and ECGs, and also the unusual association with hearing loss. We had a session on gene therapy and talked a bit about the fact that gene therapy, although it feels like it's new, has actually been discussed for over 50 years. And then I'm a big fan of studying the autonomic nervous system, which controls, of course, so many of your functions, and probably has a role in your heart symptoms and your heart function. And then we talked a little bit about a different type of SADS condition. So today we're going to talk, along with the theme about SADS and medications, I don't know if anyone wants to put in the chat who this fellow is, or what this molecule is. We should have awarded a prize if someone could name this molecule. The gentleman is Sir James Black, and the molecule is propranolol. And so he was a Scottish physician who ended up choosing not to pursue clinical medicine, but was particularly interested in improving treatments, and so studied physiology and studied adrenaline. And we talk often about adrenaline or epinephrine, and adrenaline being an important component of the SADS conditions. Many of our SADS conditions have events associated with excitement or exercise or even stress. So these are all things. So he developed this molecule, which actually has been an incredible addition to the medication. So propranolol is, of course, a type of beta blocker. And quite appropriately, he won the Nobel Prize about 30 years later, so in 1988. And there he is. And so that's a great segue to me. Our guest today is worthy of a Nobel Prize. Dr. Roxane Carr is an amazing colleague and works here in Vancouver at the BC Children's Hospital, and has been an incredible resource right from when I started on staff a long time ago, aging us both, and works as a clinical professor at the University of British Columbia in pharmaceutical science, and really has tremendous expertise both in intensive care and cardiac conditions, and has lots of experience with particularly medications and understanding them at a level much higher than most physicians. So delighted to bring Dr. Carr into the studio here, and I will stop sharing my slides and welcome her to our studio. So I'm only going to last about 1 or 2 minutes calling you Dr. Carr, because I've known you for so long. So if I slip into a Roxane periodically, forgive me. But you definitely, delighted to have you here.
Thank you so much. I'm delighted to be here.
Now, I like to take a bit of a journey back with you so that our audience can understand exactly who our guest is, and so people don't think I'm just pulling random volunteers out of the hospital corridors. Tell us a bit about your journey, your educational journey, and how you landed where you are.
Yeah, it's like back in time. So I studied pharmacy, and at the time it was a Bachelor of Science in Pharmacy degree at the University of British Columbia, which was the degree you needed to be licensed as a pharmacist. So our community practice type pharmacist. And following that, I actually did a residency in pharmacy practice in hospital practice, which isn't necessary to be licensed. However, many, if not most, pharmacists that you work with in hospitals will have done extra postgraduate training. So I did that, funnily enough, in adult internal medicine at Vancouver General Hospital. And then I worked for a little bit and decided that I wanted to do more. So I went back to school and did my Doctor of Pharmacy degree, also at the University of British Columbia. And that's really where I kind of fell in love with pediatric medicine and pediatric pharmacotherapy. And so I ended up going and doing a postdoctorate in at the Ohio State University in Columbus, Ohio, with an amazing mentor, Dr. Milap Nahata, where I spent about 2.5 years doing research, teaching, really focusing on the sort of unique needs that children have when it comes to their drug therapy, because often we see that they respond to some medications differently than adults might, or in some cases there's just things we have to take into account that maybe we don't think about when we're dealing with adult patients. So how a medication tastes, what type of dose do they need, how can they communicate some of the side effects, and a lot of work around how do we get children to take medications, especially if they don't like the taste or they can't swallow a tablet, and teaching them how to do that, etc. And then I made my way back here to back home to Vancouver and at BC Children's Hospital, where I've been working in critical care and also at the university.
I didn't realize that you'd done an additional postdoc after all your other work. So you have really done a lot of hard work to become very knowledgeable, and that certainly shows. I mean, for our audience, I cannot tell you how nice it is to have a colleague like Dr. Carr on rounds and also guiding treatments. I remember early on in my career just having not knowing where I could find in-depth information about medications. And I remember, and funny that you mentioned the taste. There's one medication that we use. We don't use it very much for SADS conditions, but it tastes so awful that there are actually publications about how to mix it in a way that patients can take it. So so very important. And pediatrics is really such a tiny portion of the pharmaceutical industry and the focus. So, and SADS conditions, of course, are very important in young children and young adults. So, well, thank you. So let's jump in here, because one of the mainstays of treating SADS conditions, sudden arrhythmia death syndromes, really one of the mainstays is medication. And so before we jump into the medication, I want to do a bit of a backwards journey here. Long QT syndrome. So I think we have a very educated audience. Many of them know long QT syndrome is an electrical disease. So your heart is structurally normal, but really caused by abnormalities in how the ions in your heart flow. So potassium in particular, how it moves. The pharmacology side of things really came into the spotlight when people started realizing that medications were causing long QT syndrome, basically. Can you take us back a bit through that? How did anyone even figure that out?
Yeah, it's been an interesting journey, because I think the first time it was identified was actually, and I shudder saying this, over 100 years ago in the 1920s, and where it was first identified that quinidine prolonged QT interval. And I think that was probably before we really understood, you know, as much as we do certainly now, about the various channels and the impact of some of the ions in the heart. And so that was sort of the first drug that was identified. And then over time, more medications, one is, in fairness, as they were being developed, we started to identify more and more medications as impacting conduction in the heart, in particular the QT interval, because that's something that's, relatively easy to see if you have an EKG. You don't have to do any sort of, more invasive testing or looking really into the structure of the heart to be able to identify that. And I think that we've sort of, over time, almost come maybe a little bit, we've shifted and recognized this more and more. And it's actually one of the most common reasons why medications end up not making it to market, or getting pulled after, so removed from the market by the manufacturers, is because gets identified that they impact heart rhythm, in particular the QT interval. And so we've certainly seen a number of medications that don't even make it to market because they end up looking at that so early in the clinical trials, and in particularly even in phase 1 trials, where they're looking at the safety of a new molecule. And we maybe have shifted to, I think, where we're potentially have overcorrected that risk. So it certainly has, developed over a long period of time. I think where we really saw much of that study and much awareness were in the 1980s and the 1990s, and where we saw medications such as cisapride, which was being used for gut motility, for severe gastroesophageal reflux disease, where that ended up being removed from the market voluntarily because of the risk of torsades and QT prolongation. And there have been many others since.
So I didn't realize that our journey goes back 100 years, but not surprising given the slides I show at the beginning of our history. People were discovering incredible things, and our scientific understanding, of course, has advanced. So, and quinidine is a drug that largely had served its purpose, and then within the SADS conditions has made a resurgence, being used in particular for Brugada syndrome, and also for some of the rare arrhythmias where the sodium channel may be involved. So, conditions where you have sodium channel abnormalities, and quinidine is now being used. Again, it is actually a fairly difficult drug to obtain, because it is not in widespread use. So the QT prolongation often shows up on an ECG. We have, as you say, we have potentially overcorrected a little. And in treating people who have known long QT, we present them with this fairly extensive list of medications to avoid. Tell us a bit about sort of your thoughts as from the pharmacy side about that list, and is it really important that families pay attention to this? Sort of, if you're in an emergency, and that should people not get antibiotics, those kind of things. So give us some of the common sense approaches to this rather overwhelming amount of information.
Yeah, and sort of a bit of a shout out to the crediblemeds.org, that sort of maintains a very evidence-based list that is available on the web. So I think that one of the things we always have to think about when we're thinking about medications that can prolong QT or potentially are pro-arrhythmogenic is the mechanism by which that occurs. And for some medications, it's because that impacts electrolytes. So you'll see medications on that list that the only reason they're on the list is because they're associated with causing hypokalemia or hypomagnesemia or hypocalcemia, where really the risk of that can be mitigated by monitoring and appropriate supplementation of those electrolytes. So those medications, as long as the patient's electrolytes are in the normal range, can be safe to use. Then there are medications that actually impact either the production of the proteins for the potassium channels themselves. Those are a bit more concerning, and those are ones that we typically say, okay, those really should be avoided, particularly in people who have known long QT syndrome. And then there are medications that may do that to a minor extent, but if you're just using that one medication by itself, it's probably safe, but the risk comes in with drug interactions and an additive effect. So many of the medications that appear on these lists and that have been associated with long QT get metabolized through the cytochrome P450 enzyme system in the liver. And those enzyme systems are responsible for metabolizing most medications, not all, but most medications that do get metabolized, so go through the liver for breakdown. And they are prone to, well, one, we call them pharmacogenomic alterations. So we have people who may be slow or fast or ultra fast metabolizers of those various enzyme pathways, but they also get inhibited by many medications. And those medications that are cytochrome P450 inhibitors, what that means is that it slows the breakdown of other medications that rely on that pathway. And so that means that you don't clear that medication as quickly, and it is circulating in your bloodstream and exerting its effects for longer and potentially at higher doses. And when you start to see an additive impact with that, you run into increased risk of developing an arrhythmia or prolongation of the QT interval. So some of the common ones we think about are some of the antibiotics, particularly macrolide antibiotics, so clarithromycin, azithromycin. Some antifungals will do that, so fluconazole, basically the azole antifungal group. We see that with some medications that are used for psychiatric conditions. So some of our kind of antipsychotic medications that might be used for schizophrenia or for behavioral issues, things like haloperidol. And you can certainly see that with anti-nauseants. So droperidol, ondansetron has been associated. And also I mentioned cisapride earlier for GI motility, domperidone, which is available in Canada. It's also used to promote lactation in people who are breastfeeding. And then methadone, which is an opioid, can be used for pain and also for substance use disorder placement. And so when we're contemplating those medications, I think that the things that patients want to think about is how many medications are we taking and what are we changing? So for instance, somebody who comes in who is profusely vomiting and has severe nausea or maybe undergoing treatment for cancer, a medication like ondansetron is pretty essential for their quality of life and to manage those symptoms. And so with discussion with the team and monitoring of their QT and avoidance of other medications, they can safely take that. If somebody is going on and off of antibiotics or there are other options, for instance, there are many other options to macrolide antibiotics for most infectious diseases, we would recommend using an antibiotic that does not impact the QT interval because we know that there are safe and at least as effective alternatives. And I think that the last thing is really, it's always very tempting to use Dr. Google or Dr. Reddit, but when it comes to interpreting the content, I think it's really important to have those discussions with physicians and pharmacists who can contextualize the information for an individual's unique circumstances and situation.
So you covered a lot there, and I want to drill down on some of these very important points. Um, there's obviously quite a few layers here to how medications affect individuals, and in general, our approach is not particularly individualized for many of these conditions. We write a prescription, often based on something like weight, or not even based on weight. It's we just sort of write, well, this is a convenient tablet, and then Johnny has incredible side effects from the same dose that his sister or his dad is taking, with no side effects. So the concept of genetic influences and medication interactions, I don't think we do a great job of in general in medicine. But in the SADS conditions, it would be amazing to have a pharmacist attached to the SADS the SADS clinics, and in Canada we have a nice network of those. So here, another point I really want to emphasize is that once we add multiple medications or other factors, electrolyte disturbances, different categories of medications that might interact, when you start affecting two limbs of the same pathway. Mm-hmm. So, and then I just want to make sure our audience understands also that they are, they come in for their appointment. Let's focus on long QT, because that really is where we talk a lot about medication interactions. We talk about it a little bit in Brugada, but the medications in Brugada are not as numerous and as diverse. But it's overwhelming. I think the family gets this diagnosis, and we give them a list of, often it's a page or two. Don't take these medications, and many of them can be used safely in urgent conditions. Many of them are on the list, and I'm glad you referred to the Credible Meds, wonderful resource. But people often will come into the pharmacy thinking that there is some magical file that exists about them and what they can and can't do. And I really want to encourage our families, our patients with SADS conditions, in a way, they have to be the champions, especially if they're not always at the same pharmacy, or they go to a walk-in clinic and someone writes them a prescription. So ultimately, the patient, and in the pediatric setting, their family, you're ultimately the guardian of what you're putting in your body. Not unlike your food, and you can't necessarily rely on some flag coming up in the system that says, oh, you have long QT syndrome, here's the no drugs. So just a real sort of reminder. It's a bit of a sobering truth that we are pushing. We're sort of saying don't do this, but we don't actually have a lot of structural things in place to help our families. So we just give them this website or lists. So great to have you outlining the complexity of this.
Thanks. Sure. The one other thing I would add is, and I encourage patients and their families to find a pharmacy that is, one, convenient for them and that they like, and build that relationship. And as you said, don't assume that they know anything about your medical history when you go into that pharmacy, but by building that relationship and really advocating to say, hey, I have this condition, or my child has this condition, can you check? Can you please check? It just serves as that reminder. But once you've built that relationship, similar that you would with, a physician, particularly your cardiologist, then they get to know you, and that will be more on their radar. And again, they can help then to contextualize it for you, versus if you're always going to different pharmacies and dealing with different people, it's more likely that information is going to be lost or not recognized.
Yeah, no, that's a great point. I think another point, we've talked a little bit about genetics and long QT, and I just want to clarify some of that. So we know in congenital long QT syndrome, where one, often will have a genetic variant that causes your heart's electrical system to be different. That is the type that we often focus on in the SADS space. But it's actually much more common to have a prolonged QT interval from medication
Mhm.
and medication interactions. So, some people may have been diagnosed with a SADS condition because they were taking a few medications, and when they're off the medications, their risk goes down, and they actually need a very different treatment algorithm than those who have a genetic predisposition to long QT.
Yeah, absolutely. That diagnosis is really, really key, because I, as far as I know, don't have a diagnosis of that, but I could take a medication cocktail that would result in my QT being prolonged on EKG.
Now, I want to shift direction a little bit here. What we've talked a bit about long QT, but in SADS conditions in general, um, we are often using medications to manage the condition. And in my experience, the most common medication we use is beta blockers. And I want to talk a little bit about beta blockers, not just because I talked about uh, their origin and winning the Nobel Prize, but really because I think they are, one of the most common prescribed medications in the world. And we use them, very frequently. So for our audience, take us a bit through what is a beta blocker. What does that even mean? Because it's a very confusing term, because people talk about blocked vessels in their heart, and here we are using a blocker. So
Yeah, it is a confusing term. And added to that, there are a lot of different drugs that are considered beta blockers. So beta blocker means that the medication blocks or antagonizes the beta adrenergic receptors. And the beta adrenergic receptors play a role in heart rate and conduction in the heart, as well as they actually, believe it or not, because we use them for high blood pressure, hypertension, they actually help to dilate the blood vessels. If so, kind of a, or sorry, they actually help to constrict the blood vessels as well as a minor pathway. Um, and so, we think about the impact of beta blockers, particularly, well, in SADS conditions, particularly long QT, because the idea is that they block that adrenergic, the adrenaline or epinephrine kind of boost that actually happens to the heart, that then triggers the increased heart rate and potentially an arrhythmia. They've certainly been around for a long time. Not all beta blockers are the same. When we're talking about specifically long QT syndrome, really the two mainstay ones are what we call non-selective beta blockers. So they hit the beta 1 and the beta 2 receptors. And that those are propranolol, sort of the first in class, shall we say, and nadolol. Other beta blockers that somebody might take for high blood pressure or other reasons, such as metoprolol or atenolol, haven't really been found to be as effective as propranolol and nadolol for long QT. So those are really our two mainstay treatment. Propranolol, there is a commercially available liquid formulation, which, and also we have recipes to make a liquid formulation, which has made it quite appealing for use in children because they don't have to worry about swallowing a tablet or a capsule.
the it's very important that point about some beta blockers are better than others, particularly long QT, CPVT. So people that if people that are seeing clinicians that may be treating 100 high blood pressure cases and one long QT case, there's a difference in what we want to use and what works best. Starting beta blockers, we have a concern about side effects, and I'm a bit biased, of course, in part because I see the life-saving effects of the beta blockers. And so but people do often feel a bit tired, and especially when they start, and not surprising if you're actually reducing how much adrenaline they're activate, or how much the effect their adrenaline has. But in your experience, are the side effects mostly manageable, or?
Yeah, I think, well, I like to say that beta blockers, and probably in particular propranolol, because it's been around the longest, I have been a bit maligned, I think, in healthcare. And so certainly one of the ways that we can mitigate some of the side effects is to start with a low dose and titrate it up slowly. One, for things like the fatigue, which I think there's the evidence from studies certainly shows that there is an association with beta blocker use in that general fatigue because it impacts adrenaline. We know that people can develop a tolerance to that, right? So they and it's not even that they get used to it, it's that it gets better over time as their body gets used to it, to being on the medication. What's interesting is there are a lot of side effects for beta blockers, especially around mental health. So around depression, sort of fogginess, memory loss, that I would say are really myths and not facts. And recently, probably in I think 2021, there was a group out of Germany that actually did a great systematic review looking at the psychological side effects of beta blockers. And they ended up reviewing almost 300 studies. Over 50,000 patients were included in these studies. And when they looked at it, they really said there was no effect of beta blockers on the frequency of depression, of appetite loss, of memory loss, of loss of libido, and that those things occurred just as frequently in participants in those studies who were not receiving beta blockers. Now, we do know that beta blockers probably actually have a positive effect on anxiety. So there may be some benefit in that case. So I think when we're thinking about the side effects, and I really encourage anybody who's writing a paper about medication and use for long QT or SADS conditions and talking about beta blockers to start to reverse this myth, because we see it. I was looking at a paper a few weeks ago that was published in 2024, and it still repeated this myth, even though we actually have, a really robust scientific systematic review that discounts that, as well as other studies as well, to stop repeating that myth. And I think that, as we work with our patients with that, one of the things that I sort of have found is that it can almost become a confirmation bias, which is you've just been given this diagnosis. It's scary. You have a lot of uncertainty. You're trying to kind of figure out, how am I going to move forward with this diagnosis? For parents, it's, how am I going to keep my child safe? What do I do? It's a lot to take in. And we start a medication at the same time. And so then we start and we say, we're going to look for this, right? We're going to look for depression. We're going to look for impacts on mental health, without taking into account that maybe there are other things going on for that patient or that family, and also realizing that, it's the classic example of, if I say to you, wow, I've noticed there's a lot more yellow cars on the street, you are going to walk outside and start to notice every yellow car and go, yeah, she was right, even though there's no more yellow cars than there were a week ago and you didn't notice them at that time. And I think that I mean, that's a bit of a silly example, and I don't want to minimize, concerns about mental health, but I think that we've started to look for it and say, oh, it's the beta blocker, when actually there are other things going on, or potentially there was depression happening before they started on the medication. So I really do think people really, and healthcare professionals really need to help patients and their families with that, because they can easily pull up a paper that just says that as a fact, but actually is not quoting the most up-to-date science around that.
Yeah, no, those are some really important points. And I'll just add, another thing that is sometimes done, and and we're not going to talk about activity here, but we've certainly talked about exercise in this forum a few times, and we're very, in favor of continuing to be active. But often, particularly in some clinics, we hand them a diagnosis of long QT or CPVT, or sometimes not even a diagnosis. We say, I think, I want you to be on this medicine and stop doing this exercise that you love doing. And suddenly the person's body doesn't feel good. They don't feel good. They're missing their participation. We say, well, of course, it's the medication that has resulted in this, but we usually are doing a number of very impactful things. So yeah, no, I agree. And there are certainly ways to, to mitigate some of the things we do see, especially in, in people who are not, eating breakfast or drinking enough fluids, suddenly they have more dizziness, because the beta blockers do lower your blood pressure a little bit. So if you're prone to low blood pressure in the morning, then you have to be aware of that. So I think we're in agreement that we're not saying there are no potential side effects, and we certainly think that some of them are manageable, and some are probably are pre-implanted. So we provide you with a cue to look for them. Please, yeah.
Oh yeah, I was just going to say, I think the other thing is for things like the dizziness, or aspects that are bothersome for patients, I really strongly encourage people to don't stop taking your medication. You need to talk to your physician, and often they can reduce the dose and see if those side effects get better, and then potentially try to go up again. But instead of just stopping it, because they are, this is a life-saving medication, it is really important to think about, how can I manage this? And as I mentioned before, most of the side effects actually get better with time, or we can manage by adjusting the dose to what we refer to as the minimum effective dose, and then trying again to go up and finding that for the individual patient.
Yeah, no, thank you for making that very important point, especially beta blockers. We don't like to see them stopped abruptly, because your body has been adapting and has built more of these beta receptors. And suddenly, if you take away the blocker, you're very much at risk for a dangerous arrhythmia. And in fact, most of the events that we see in people who are normally treated well with long QT or CPVT, even missing a dose or two really can place you at risk. So talk to your team if you're struggling with the medication, but it can be dangerous, in fact, to take it on yourself, to say, well, I'm better off without, because that is definitely unlikely to be the case. In our remaining sort of minute, and there are so many other things that we can talk about, because the medications and the pharmacology they really impact so much of what we do. Your thoughts about what's coming? Are we going to be are we going to all get an individual molecule that treats us? Are we still going to be having 20 years from now, when we talk about this, are we going to still be using beta blockers, or is something else coming?
Yeah, I think it's a really exciting time. Obviously, you can never predict the future, but I think that as we better understand the genetics of the conditions, when we can identify them, it allows for more targeted therapy around that cause. So there's some really interesting work happening with monoclonal antibodies, working towards the genes that actually encode the proteins for the potassium channels, which I think is really, really exciting. I think we're also looking at so that's immunotherapy. I think we're going to see some interesting other medications coming down the pipeline soon, looking at optimizing the function through those channels. Who knows? We're seeing a lot of, I'm not aware of anything on the radar yet, but we're actually seeing in a lot of conditions, in particular rare diseases, therapies both that modify enzymes, but also that modify the gene itself. I do know that the Canadian SADS Foundation has a great link on their website of sort of clinical trials and research, and I encourage people to, check that out. And I suspect the way that we all know research goes is check back semi-frequently, because things are, there's always new studies and new things that are being offered for those types of opportunities. And also ask your healthcare team about them, because I think that we're going to see some really interesting developments. I can't promise that we won't still be using beta blockers in the next 10 or 20 years, because, they've got a we're coming close to, wow, what are we at? 70 or 80-year history with those medications. But I think there's some really exciting times ahead.
Roxane, it's been a delight to talk to you, and you provide so much depth to our understanding of the pharmacy, the pharmacology of what we're doing here. So I'm sure our audience really appreciates this, deeper understanding, and it's been an absolute delight to have you here today.
Thank you. It's been a real pleasure, and I really thank you so much for inviting me.
So that's we're at time, but what a great resource. And as we talked about, we encourage you to establish those relationships with your pharmacy, and and take your medication as prescribed, and those other messages. But it is such an important part of our looking after ourselves and looking after SADS conditions. So thanks so much. Just a reminder, so we're back in 3 weeks with Dr. Fridman, and we're going to talk about some of that research that Dr. Carr was alluding to. So that's it for me. Happy Halloween for those of you who celebrate that, and we will see you next month.